Bedside. Good morning, everybody. Thanks for coming today. With Angela on a cruise somewhere in the Caribbean, there will be no other announcements this morning. So this morning we're going to try something new. I think it was Dr. Shippy Wallace's idea. And if everybody goes to their iPad or their smartphone, which I know you probably have in your hands and you're looking at it right now, and you enter the text number 22333, and then in the message, body of the message, enter UW Ortho, you'll get a reply, and that will register you for being able to answer questions during grand rounds. Your usual rates will apply for that text message. So this morning, we have somewhat of a different grand rounds, which is nice. It's a little bit infrequent that we have talks that are really focused on statistics and epidemiology. And we're going to talk about what's a hot topic right now, patient-reported outcomes, or PROs. And the title of the talk is Patient-Reported Outcomes from Bench to Bedside. And we're going to have Dr. Shippy Wallace introduce the topic. We have Amy Cizik, who is a grad student with an MPH in biostats epidemiology. Antoinette Lindberg, Dr. Lindberg, one of our tumor surgeons at Children's Hospital, and then Dr. Davidson, who also has an MPH in health outcomes research. So with that, we'll get started with Dr. Shippy Wallace.
So I just wanted to try out this new polling technology. So let's see if we can get this to work. Okay, so see if you can get your answers to come up here. And if you're at Harborview, you can answer too, so. Changes in real time. It's a race. Just choose the letter that you want to. It's working good. We'll do a new one.
We need other.
Wow, I'm surprised that it's down to those two. Okay. Oh, wait. Oh, yeah. Okay, okay. So this is the first real question for the talk. Today's Grand Rounds is going to be about patient-reported outcomes. And I wanted to get you thinking from the patient's perspective. So if you could answer this question, what's the main reason that patients come to see you initially? And just keep this in mind as we go through the rest of today's talk. So today's about patient-reported outcomes. I'm Sara Wallace. I'm one of the fourth-year residents. I wanted to thank Drs. Lindberg, Davidson, and Amy Cizik for presenting today as well. As an overview, I'm first going to attempt to answer the question, what are patient-reported outcomes and how do they differ from traditionally reported outcomes? Dr. Lindberg will then further characterize different types of patient-reported outcomes and describe their development. Dr. Davidson will describe several health policy implications, and finally, Amy Cizik will use her research to sort of bring it all together. And along the way, we'll be collecting reports from the audience as well. So here's another question to continue to keep you involved in an attempt to keep this relevant. What is your most common indication for surgery? Pain, disability, quality of life, based on an x-ray or diagnosis and prevention or prophylaxis. So keep these answers in mind, and keep in mind that they are truly responses that can only come from the patient. So to start with a definition, patient-reported outcomes are validated patient questions that seek to determine the patient's assessment of their health state. And these outcomes can include patient symptoms, their functional status, measures of their quality of life, and they're not simply a patient's opinion. It has to refer directly to their health state in some way. They're often wrongly referred to as outcome measures since they actually are measuring a state of health or just the patient's health and not necessarily an outcome. But by comparing patients' health at different points in time, the outcome of the care can then be deducted. But so don't get too hung up on the terminology, just go with it for now. Here's an example of a patient-reported outcome. This is the Oxford Knee Score. It's a survey that evaluates patients' reported outcomes to determine the patient's current health state as it relates to their knee. In this questionnaire, there's a series of 12 questions, and a score is tallied, and a lower score indicates that the patient has more severe knee arthritis, more debilitating knee pain, poorer function, and a score above 40 indicates that the patient's knee is actually doing pretty well. So this is just one example. So are these patient-reported outcomes? Was your pain managed appropriately after surgery? Were you treated with respect by your surgeon? And how were the accommodations? How was the bed? How was the food? Exactly, perfect. Okay, so these are not patient-reported outcomes. It's important not to confuse these sorts of experience measures with what is a patient-reported outcome. These experience measures revolve around the humanity of care and patients being treated with respect, patients not waiting for too long. We value their time. This is not what we're here to talk about today, so I just wanted to clarify that. Traditional outcome measures are various measurements that oftentimes reflect an end result or a measurable event, such as death or non-union, osteomyelitis, infection, DVT, discharge from the hospital, or even range of motion, things you measure on physical exam. And we see and track these most commonly. These are most familiar to us. Different types of traditional measures are also cost measures or resource use measures. Resource use that refers to how often do we get a CT scan or how often do we get an MRI in the setting of knee pain, things like that. So these are what we're most used to seeing, but that's not what we're talking about today. It's important to keep in mind that both patient-reported outcome measures and traditional outcome measures can be subjective. And regardless, they should both be validated and standardized and something that's reliable in order to be of use to us. So the reason I asked you those poll questions today initially is because the patients aren't thinking about their knee range of motion or 30-day mortality or DVT when they come to you for care. The outcomes they care about is hurting less or doing more, and your goal is actually usually much the same when you sign them up for surgery. So shouldn't we be keeping track of this? Some of you may be asking, aren't we already collecting patient-reported outcome measures? Well, some people might be, but really the history, when you're filling out a history and a physical exam, I mean, those are really from our perspective and not necessarily from the patient's. The way we do this now in terms of taking a history and documenting that in a text paragraph, it's inconsistent, it's inefficient, there's no standardization, it's time consuming for everybody involved, and it's not truly patient reported in the sense that we're talking about here. On the other hand, if you're collecting this type of data for research, it may actually qualify as a patient reported outcome, but it's oftentimes on pencil and paper, and it's inefficient, and it's not integrated into the electronic health record. And so it's not as useful for clinical care and decision making as it is for your research. And most importantly, it's not going to meet meaningful use requirements. So why do we need to talk about this today? Why are we considering patients' views? Why is this important? Most healthcare aims to reduce symptoms, minimize disability, improve quality of life, and these are really only things that patients can assess. Patients welcome being involved in their care, and it may actually have benefits to their health in and of itself just to ask them about how they're doing. Patients' response rates are invariably better than the surgeon's response rate, and only a patient has to complete, they only have to complete one questionnaire, whereas we have to do multiple questionnaires in a clinic. So we could potentially get better data by using these measures. And along those lines, it avoids observer bias, which is inevitable if you're asking surgeons to assess their own practice. Considering patients' views also increases public accountability of health services and healthcare professionals. And most significantly, and what I really want to emphasize, is that patient-reported outcomes will be introduced into meaningful use in bundled payments, and that's going to happen with increasing requirements in months to come. So why do we need to focus on this today? Because we have to, essentially, and also we should want to. Good orthopedic care requires knowledge of a patient's history in terms of their pain and functional limitations. Standardized and validated patient measures of patient-reported outcomes can provide this information for us, and they can do it efficiently. Integrating patient-reported outcomes into routine visits in our electronic health record can provide key information to monitor their symptoms over time, and patient-reported data can be used to support our clinical decision-making. And this will be mandatory. It can be used to assess treatment effectiveness for value-based reimbursements, and it will actually be required for reimbursement in the near future. So we should make sure that the data we're collecting is an accurate reflection of the patient's current health state and an accurate reflection of the impact of our care. So we have several challenges ahead. How can we possibly fit more questions, paperwork, and data entry into one clinic visit? It's obviously going to take a lot of help from IT, and patients are going to have to be able to import this data themselves. As of now, HIPAA is a major hurdle to allowing patients to enter their own data into their health record, and we need a method of working around this. Another obvious question is who's going to pay for this? I have no idea. How can we achieve high rates of patient participation, especially among older patients, sicker patients, underrepresented patients? We have yet to determine the answers to this. And what about the other dimensions of care, like the effectiveness of care, safety, complications, and how do we adjust for patient experiences, their perception of the respect that they were given or not given, and their dignity? And one hugely important point is that attributing patient-reported outcomes to the quality of care possesses several challenges. This doesn't directly relate to one another necessarily, so we'll need to, that's a talk in and of itself, essentially. And another point that I'm sure everyone at Harborview is wondering is how are we going to handle outcomes after traumatic events, and what can be used as a baseline in those situations for the patient's state of health, and how good is the patient's recall after a traumatic event about their baseline state of health? And lastly, who's going to use this data? Who will it belong to? And how do we prevent misuse against both providers and the patient? All questions that we have yet to answer. So now Dr. Lindberg is going to discuss the subtypes of patient-reported outcomes and the development of these instruments for use in our practice. Thanks.
All right, so my section is really back down to really basic ideas about these type of outcomes measures, and you can realize that you actually probably do know a little bit more than you probably remember. So we're going to look at some of the different types of outcomes measures, like generic versus disease-specific, the different location-specific ones, and I'm going to talk a little bit about the theory behind how you actually develop these and turn it in from an idea to an actual functional validated instrument. So there are generic measures, and the ones that you're probably most familiar are the short form 36. So this is kind of like one of the original generic general health state outcomes measures. This was developed by Rand a while ago. It's something that's on public domain, so you can actually do what I did, which is Google it and find it in about 2 seconds, and all the questions are there. Another example, like the analog scale for pain, it's probably one of the most simple drilled down versions of a patient-reported outcome, but we just don't think of it as one. But it too went through all the different ways to measure and make sure it's a validated instrument. So you can use these types of generic measures across a bunch of different disease types, states, and different populations, which is good because then you can compare them. But then you are really limited in being able to find really subtle changes. And I think in orthopedics, that becomes a big issue with being able to apply these generic measures. There's also a lot of measures that are very specific for disease populations, and being a tumor doctor, there's a couple that are used specifically for that population. So it doesn't talk about a specific body part, but it's how their specific disease affects how they perceive everything. And their questions on these are so different from other things that we collect. Like how do you think that your limb looks? How do you use it? And these are things that we don't really talk about as much in our own way that we measure our outcomes. And then finally, the ones that you guys are probably most familiar with are the location-specific measures. There's a handful for every joint and body part that we study. In the shoulder, you have things like the ASES score, the dash and the quick dash. And again, dash, quick dash run across the entire upper extremity. The Oxford elbow score, and then some other hand measures too. And again, with hip, we have things like the WOMAC and the Oxford hip score. For the knee, you have, again, IKDC and a few other ones. And again, there's same for foot and ankle and other measures used for spine issues. And so the big thing is we have some of these that we use already, but it takes a lot of work to create these tools and actually have them become useful. And there's a theory behind how to develop them. They call it the spoken wheel. And you don't have to remember all the steps. You don't have to remember how many there are or what it's called, but just the idea that it's a cyclical process and you have to constantly be redeveloping, and all the different steps that go into making one of these tools. So first one is just you have to identify what you want to ask. I mean, it sounds like a really simple thing, but you have to know what you're trying to ask. What are you trying to answer? What are you trying to get at? And then you come up with what are questions that I can ask to actually answer that question. What will actually answer the questions we have, what will actually look at what the patients find important. And then you have to start creating questions, trying them out, seeing if they actually do measure what you want. Test it on a population and try to validate it and actually make sure that you are measuring what you want and that you can actually differentiate the differences between population and states. And then most importantly, I think people forget this part, is that you have to then modify it. If it's not measuring what you want it to measure, you have to kind of go back to the beginning, which is why you have this wheel phenomenon, and revise it so that it is measuring what you want and you can validate it for what you're trying to get at. So I think if nothing else, the two things I want you to get out of this segment of this talk is that you can't just put a list of questions together and then call it a patient-reported outcomes measure. These are very carefully created and validated instruments. So, it's not just making a bunch of questions. These are designed to be very specific and very organized so that you have the smallest amount of questions to get at the most information you want and to differentiate differences between populations. And then the second thing that I really want you guys to take home is that these measures are also, you need to think of them also as tools. They're instruments. So they're designed with very specific populations in mind, and they're validated for very specific populations. This is a problem in my practice because a lot of these instruments are not validated for pediatric populations, and that's something that we need to work on. But I can't just take any of these measures and then suddenly use them on a population of kids and expect that to be useful information. So the way to remember it is if you use the wrong outcomes measure, you're essentially using the wrong tool. So it really is the same thing as taking a screwdriver and trying to hit a nail. Even if you take the best instrument and misapply it in the wrong population or wrong topic, it's not going to be useful. So with those, if you remember nothing else, those two things I think will take you a long way in terms of how you interpret research that you read and how you design your own studies, and how we look at how these types of measures are going to start getting involved in our practice. So with that, I'm going to pass everything off to Dr. Davidson and talk about how this applies to health policies.
Thank you very much. So now I'm going to get really esoteric. Sorry. Hopefully I need to have more of those survey questions that Sara had to keep people's attention at this point, but we'll see how it goes. So as Antoinette was talking about, these quality of life measures are a really big umbrella term. And we have the patient-reported outcomes that can be disease-specific, like she was talking about. They can be location-specific. And then you have your quality of life measures. So Antoinette was talking about the SF-36, which is one of the generic measures, probably one of the best known of these measures. And this gives us information, but the score that you get in and of itself doesn't really tell us anything. It's hard to interpret. So the next layer are these health state utility scores, and these do give us information about comprehensive quality of life in a format that we can then use. So how do we get these scores? There's two main categories of ways to derive these scores. There's direct measurements and indirect measurements. The direct measurement techniques is actually sitting down with whoever you're eliciting these scores from and using one of those three techniques, standard gamble, time trade-off, or visual analog scale, which we're not going to get into because it's really technical and probably isn't all that important to our discussion this morning. Or there's indirect measurements, and these are from questionnaires. And there's three main questionnaires that you can see there, the EQ5D, the SF60, and the HUI, because we like all these fancy acronyms and all these patient-reported outcomes. And the idea with that is they fill out a questionnaire, we get our scores, they give us the same score value that the direct measurements give us. So what are these utility scores? Well, it's typically a range from 0 to 1, where 0 represents death and 1 is perfect health. Best way to explain it is to use an example. So if you elicit a score of 0.6, by the theory of all of this, what that means is that the typical person is going to be indifferent to two treatment options. One option is a treatment that carries with it a 40% chance of death, but a 60% chance of improving their current health to perfect health. And the other option is 100% chance of keeping their current health state. So it's a little bit of a weird term. It's very theoretical, but that's what those values actually mean. So we can kind of take examples of this. So in the oncology world, there have been studies done on this, not many studies, but a few. One study of young adults who had survived, they'd been cured from their pediatric bone sarcoma. They rated their overall health at 0.8. So again, that means that they'd be willing to accept the treatment with a 20% chance of death to improve where they were up to perfect health. Another comparison that might be a little bit more shocking for tumor surgeons is a comparison of young adults, again, who had survived pediatric bone sarcomas, different study from the first, and comparing amputation and limb salvage. And really not a whole lot different in how they rated their overall health, despite what we might want to think with all the limb salvage surgery that we do. Pretty similar. This has also been looked at in more common orthopedic populations, so hip arthritis, chronic osteoarthritis of the hip is said to have a utility score of 0.6, which seems really low, but the good news is a successful, well-done primary total hip really improves that health state up to almost perfect health. And then you can see some of the other examples all the way down to a chronically infected total hip, which carries with it a really low utility score. So we can use these measures as a primary outcome for a study in and of themselves, or we can kind of take it up another level. And the next level would be a decision analysis. And this is going to take these health state utility scores, integrate the probabilities of the different outcomes that can come from a treatment to give you a better picture, or even a higher level thing is to take your decision analysis, add cost to that, and get a cost effectiveness analysis, which is becoming more and more the popular thing to be doing. And you kind of see more and more of these studies coming out in our literature. And how those are reported at the end of the day is this thing called an incremental cost per quality or quality adjusted life year gained. So that's basically saying how much money are you spending in order to improve patient reported quality of life. And in a very generic sense, this is how a cost effectiveness study goes. You'd be comparing two treatments, for example, surgery versus medical treatment. They have their various outcomes with their different probabilities, and each sort of arm has a cost and also has a health outcome. And then you roll all of that back, combining all the information of probabilities, of the cost outcomes, the health state outcomes, and you get a comparison, which down here would be, in this example, an incremental cost for quality adjusted life year gain with surgery of spending 15, whatever the units are, per quality adjusted life year gained. And another way of looking at the results from these studies is what's called the cost effectiveness plane. And it's basically just a graph. So on the x-axis, you have the effectiveness, and on the y-axis, you've got cost. And most of the studies end up in this group here, where you spend more money and you get some degree of improved health. Where you don't want to be is over here, and that's you're spending more money to get worse health. That obviously doesn't work very well, and that's called a dominated treatment. And then the other place, this is where you really want to be if you can get there. Less cost, better health. Pretty awesome, right? And that's called a dominant treatment. So medical oncologists, since none of them are here, are great people to kind of use as examples of where this can all go awry. And this example, I think, is just kind of makes the whole point of why is this important. So this is a study done in patients with diffuse large B-cell lymphoma that are being treated for attempted cure. And the question being asked is, do we use primary or secondary prophylaxis with colony stimulating factor to prevent dose reduction due to febrile neutropenia? So when people are on chemo, febrile neutropenia is a huge big deal that sometimes leads to the oncologist having to decrease the amount of chemo, which is a bad thing for treating the cancer. So on the surface, it seems like a good idea, right? Hey, we don't want them to get febrile neutropenia. Let's give them this extra drug to help. And there's actually evidence that giving the drug decreases the risk of febrile neutropenia. So much so that both the American and the European Medical Oncology Societies recommended it as a primary treatment. Previous studies all supported it, but didn't include cost. So this group, Chan et al. From Toronto, thought, let's look at the cost effectiveness. Bit of a different story. So what they found, if you remember that cost effectiveness plane, is yep, you increase the overall health by a very small amount. You can see the 0.003 quality adjusted life years gained, and you spend a fortune. So the overall cost effectiveness ratio was spending $700,000 for quality adjusted life year gained. For a bit of reference, and we'll come back to this later, the generally accepted threshold for adopting a treatment is $50,000 spent for quality adjusted life year gained. So this didn't look so good once they did the cost effectiveness study. So this is all like great, it's the research world, right? How's this going to affect clinical care? Well, in the UK, it really does, because through NICE, which I think is the National Institute for Clinical Excellence, and the NHS, the National Health Service, they use, at least in part, cost effectiveness studies to decide what they will and won't fund. So that becomes a big deal. An example that might hit closer to home is a study recently published from the UK looking at displaced proximal humerus fractures involving the surgical neck in adults. This was 2, 3, and 4-part fractures. And they compared surgical to non-surgical management. And they found that surgery was dominated in all the analyses by non-surgical management, meaning you spent more money, you had worse outcomes. And when you do these studies, you kind of do a bunch of simulations of your data just to see how robust they are. And they ended up, after that sensitivity analysis, saying there'd be a less than 10% chance that surgical treatment of displaced proximal humerus fractures would be cost effective under the NICE guidelines. And I think this study is so recent it hasn't yet made its way through all the policy steps in the UK, but the implication being there's quite a high likelihood that they won't cover it. They won't pay for it because it's not cost effective. So this type of research matters. It has implications. Another example, geriatric osteoporotic men. I don't know why the study specifically looked at that group, but they did. And they found that denosumab, compared to the other osteoporotic medications, bisphosphonates, teriparatide, was hugely cost effective. Only almost $17,000 spent for quality adjusted life year gained, far less than the kind of standard threshold of $50,000. Back to picking on the medical oncologists. Again, using that simulating factor for neutropenia in patients being treated for Hodgkin's lymphoma on chemotherapy, comparing not using it to using it, found that not using it was dominant over using it. So less cost, better outcome. That doesn't happen a lot, but here's the graph that shows it. So when they compared this, they're improving the health and they're spending less money to do it by not using this colony stimulating factor on a routine basis. So again, in the UK, cost effectiveness is used. It impacts clinical care, but that's across the pond, right? It doesn't matter, or does it? So what's going to happen with bundled payments, with ACOs, with ACNs, as they start looking at decreasing costs? Cost effectiveness is probably going to become something that's going to impact our lives on a day-to-day basis. Another example to make that point, in 2007 in the UK, guidelines were instituted to use low molecular weight heparin for total hip and total knee patients, with the idea of reducing in-hospital mortality due to venous thromboembolic events. Not really the AAOS guidelines to use low molecular weight heparin, but that's what got instituted. They then did a study after those guidelines were instituted and found, lo and behold, the VTE prevalence pretty much unchanged. If anything, maybe it was even slightly higher. There's also a higher risk of complications, a little bit so with needing to wash out wounds, but also higher thrombocytopenia, so unintended consequences of a guideline that gets instituted. So these methodologies and analyses are being used currently, at least to some extent, and in the future, probably only going to be used more and more. We're seeing it now with patient satisfaction, HCAHPS, these sorts of measures. We're about to start it even more so with bundled payments and with ACO and ACN cost plans. So I think a few questions become important. The people making these decisions about what will and won't be covered, how much will and won't be spent, what's their framework? What's their motivation? Is it purely cost saving? Is it cost effectiveness? Is it patient outcome? What actually is their framework? What is their priority? Because the future of clinical care may well be determined, at least in part, on the basis of those decisions. So their framework, their motivation becomes very important. A recent study was looking at hospitalization costs. This is going to become a huge big thing about how we can provide care to our populations, and found that these costs are affected by the estimates of treatment effect. This was sensitive to hospital length of stay for patients and how that is controlled for. There's many different factors that can influence length of stay beyond just the treatment that a patient comes to the hospital for. And they found that the method of analysis of length of stay had a huge impact on how treatment effects were estimated, meaning it becomes important how this data is analyzed. Which brings us back to that previous question about who's making the decisions, what's their motivation, what's their framework. And then ACO success has, in these authors' opinions, is dependent upon having reliable and valid information on quality and cost. And this is going to have an impact on the overall practice and individual physician levels of reimbursement. So this is all very important to our day-to-day lives. So it starts off seeming very esoteric, very quickly has real implications. Earlier, I referred to this idea of the incremental cost effectiveness ratio and this traditional threshold of $50,000 spent per quality gained. And that's from the past. And numerous studies have discussed how this is probably outdated. It certainly doesn't account for inflation or increased costs. Well, technologies are pretty unlikely to become cheaper over time. So using an outdated threshold, such as this $50,000, might bias against current technologies. Orthopaedics happens to be a very technology-dependent specialty. So as technologies evolve, if we use an outdated number to determine what will and won't be covered, maybe many of our evolving technologies will not be able to be used. So I think in order to have a voice in future decision-making on the policy level, which will have clear implications for all of us on a practice level, we have to understand the terminology, we have to understand the research methodologies, and ideally we have to contribute to the literature that, at least in part, is being used to make all of these decisions. So with that, I'd like to turn things over to Amy to go over some really cool work that she's been doing with her PhD dissertation.
Okay, so I don't know how many people in the room know who I am, but I've been in the department about 11 years as a staff scientist. And for the last 4.5, 5 years, I've been working on a PhD in health economics and outcomes. And so a little bit of what I'm going to present today is kind of a culmination of some of the topics we've discussed earlier and how I came up with a research question that is in this area, and also where I see my research career moving this research forward. So we've spent a lot of the past almost hour talking about patient-reported outcomes, and in particular, Dr. Davidson's reference to, who's going to make these decisions, who has a voice in making these decisions, and what are the methods that are going to be used to make these decisions. And so I would like to tell you today that I'm very interested in surgeon-reported outcomes, and how does this match with what patient-reported outcomes, and how do the surgeon and the patient come together to move their clinical pathway forward and have good outcomes for everyone. So you'll see PROs, I'm going to refer to SROs for most of this talk. So when I've had these discussions in the clinical setting, I feel like I hear a lot of, can we believe the patient? When they sit down and they fill out these patient-reported outcomes. And I think a great example, I've been doing a lot of work in the spine area as well, and you hear this, the patient walks into clinic after surgery. They walk into clinic after surgery, and you give them their VAS, and they mark, I have a pain of 10. And the patient walked in, and you, the surgeon, are sitting there thinking, well, you walked in. Before surgery, you were wheeled in, or you were hobbling in, and now you walk in, but you still have a pain level of 10. So how do we reconcile that clinical picture with what a patient's putting on an instrument? And the literature is growing in this area. How do we use patient-reported outcomes for surgical care and performance measurement? again, everybody's talking about wanting to hear from the patient, but are we ready to listen? How do we use this in the clinic? And does it help us? Can we make clinical decisions, or can we use it to educate patients? Here's where you were prior to surgery. Here's where you are now. Another, patient-centered care and patient-centered decisions. How do we use what's happening in the literature and evidence, and again, reconciling that with what the patient is feeling about their care. So I'd like to spend the rest of this time talking about the intersection of healthcare, economics, and outcomes. And I'm going to spend probably the first part of this talk a little bit of economic theory and how I came about designing a research question that looks at this intersection. So for some of you, especially anybody who's had a real estate transaction, the idea of an agency relationship should be familiar, but an agency relationship arises when two or more parties are acting together, and one is designated as the agent, and that agent acts on behalf of someone and has information that the principal, the other party involved, may not have expertise in. And so they come together to make a particular set of decisions. And this idea of agency theory was first brought into healthcare by a very famous, notable paper by Kenneth Arrow and the uncertainty of welfare economics and medical care. And so a lot of healthcare economics was rooted and came out of this paper. And Kenneth Arrow described a little bit of the idea of physician agency. So I want to focus on the surgeon as a principal agent. And when in my PhD training, we have a kind of the core course that teaches on cost effectiveness and health outcomes. There's a textbook by Martha Gold, and there's a phrase in the textbook that just really struck me, and it was, a representative sample of fully informed members of the community are better able to recommend societal preferences for specific health states. And when earlier in Dr. Davidson's presentation, we heard about the term the ICER, the incremental cost effectiveness ratio, and that standard by which that calculation is made is always done from the societal perspective. So the idea that we go out in the general public and we get the public's preference for whether it's a health state or if it's some other marketing or consumer, that the society has the overall standard by which we measure these things. But notice here that Gold herself said, that it needs to be fully informed members of the community. So who better to be fully informed when it comes to surgical treatment decision-making than you, the surgeons, who possess superior knowledge and have better access to these treatments. So for example, treatment A, patient, and you'll see I'm moving into the soft tissue sarcoma world, but treatment A might be that we're gonna do a surgery by which you're gonna have a lot of tissue and a lot of margin removed. And by doing so, we may leave you with a little less function and maybe a lower quality of life. And treatment B might be that, well, quality of life and a better function is more important to you, the patient, or even the surgeon. And I want to get you back on that ski slope after this surgery. And so the idea there might be that we're going to leave you with better function, knowing that there might be less local control and a potentially higher risk for local recurrence. So what if you, the surgeon, have a strong preference for one of these treatments over another, and that your preference for one of these surgeries might influence the patient's preference for this treatment, regardless of what the patient might prefer? So I think it's really important to understand, is that happening? Do surgeons have certain preferences that for their own health states that they're then transferring to the patient? So another economic paper that came out, and this is you can see this work's older, in 1998, Charles Gaffney wrote this paper about the idea of a perfect agent. And notice that the perfect agent model is where the patient takes their preference and they transfer it to the surgeon, and then the surgeon owns that patient's preference and combines it with their knowledge, and a decision is made. And you can see that, oh, my models didn't come up, that's too bad. There's supposed to be some nice looking quality of life adjusted years calculated in those white boxes. So anyway, just imagine them. The other type of decision making is informed decision making, and we hear about that one a lot. And that idea is that the surgeon takes the knowledge that they've learned over their years of experience and years of training. They impart that knowledge to the patient, And the patient then combines this new information with their preference. And this is what more often happens. And you can also see back to kind of how does this work in the clinical setting. If we were to elicit preferences from every patient when they walk in the room, it would be even more time consuming than giving them a patient-reported outcome. We could potentially do this by giving everyone an EQ5D, calculating it, getting their health state utility for a very specific, but again, you can see this would take a lot of time and effort. So what's more efficient and what happens is you, the surgeon, transfer the knowledge, patient takes that knowledge and then tries to make a decision with their preferences in mind. So I've talked about that there's these three perspectives that are going on. There's the societal perspective, which is considered the gold standard by which, you know, we fund things, and back to the discussion on policy, you know, how do we distribute and allocate these resources equitably among society? And then there's the surgeon and the patient who are actually making these decisions that affect the patient. So I took all of this theory and this background and wanted to apply it to a research question. And in order to do that in the surgical arena, there has to be an area by which there's surgical equipoise. Obviously, if one treatment is better than another, we can't, there's no uncertainty then in what type of decisions being made. So I came up, again, sarcoma offers itself to this idea that, you know, in doing an adequate margin, possibly, it's not all the time, the patient could be left with adverse function in order to get all of that tumor removed. Or the idea that you do an inadequate margin, and the reason to do an inadequate margin would be then to preserve some sort of function, whether there's a critical structure or the patient themselves, you know, that matters to them, that their function is preserved at all costs, regardless of the risk of local recurrence. So I came up with two aims to kind of answer this question. The first was valuing surgeons' health states and their treatment preferences for this type of surgery. And then I'm going to take those values and put them in a cost effectiveness model and compare them to values that have been done in the public and in patient populations that experience these health states. So more specifically, in the first aim, it was to assess surgeons' self-reported state preferences for soft tissue sarcoma and their treatment strategies. So do they lean one way or another in terms of adequate margin, adverse function versus inadequate margin, and a little higher acceptable function? And then does that influence maybe how they value those health states? Does that then predict what type of surgeon they are? And I said that I could model this and say that yes, if a surgeon has a very specific preference toward a specific health state, that will then inform how they choose what type of surgery they'll do. And I did this kind of laid out in four tasks as my methods. So reviewing the literature and developing health states for soft tissue sarcoma. There were a few papers out there that already had some health state work in this area, but the majority of them were from the oncology perspective. So focused more on depression, anxiety, and worry surrounding advanced health states, disease states, but very little information on the functional aspect of these type of surgeries. So I had to create new health states, and I based those off the SF60 health states. So domains such as anxiety, depression, function, and the SF60 also adds a vitality function. I did an online questionnaire and did a standard gamble exercise, and then recruited surgeons to participate, and then statistical analysis to analyze these results. I wanted to kind of focus on back to, this was a lot of work in and of itself, but I wanted to talk a little bit about the questionnaire development and conducting a standard gamble exercise. And Dr. Davidson referred to, typically the standard gamble is done in person, and you use a wheel, and it's a chance, it's a gaming exercise that you have people go back and forth until they become indifferent. And I actually designed this and did this on an online survey platform using software called Qualtrics. So if you ever are interested in a great survey software product, I would be happy to talk further about that. So asking surgeons about their practice demographic, their training and experience, having them rate their own healths. That's important when you're asking health state utility values. You want to know where people are starting in their own health states. And then an explicit preference. So I tried to explicitly and implicitly ask how they might weigh that surgical equipoise of inadequate margin and adequate margin. I did had a standard gamble exercise for 8 health states, and then I also did a VAS, a visual analog scale for these health states. And the reason to do both when doing this type of work is then you can validate the standard gamble against the VAS, and you can take the scores from the VAS and convert them to standard gamble utilities. So it's a way to validate what are we really seeing what we're seeing, and do people repeat those answers again in another form. So here's the questionnaire. I'm not going to go to it, but here's a screenshot of a standard gamble exercise. So you can see over on the left, choice A is you're healthy, you have perfect health, you don't have a life-threatening illness, you do not have dysfunction that limits you physically, you're able to wash and dress yourself, so you can see kind of some role functioning, social interactions. You have no ability to shop and perform other daily activities, you're able to socialize with friends and family, you have no pain, you feel calm and happy, and you have lots of energy. Wouldn't we all love to be in that health state all the time? And then, and so you're 100% in that health state, and you have a 0% chance of death. Or choice B is the idea that you have had a life-threatening illness, it has responded to treatment, you've had some surgery, you've undergone some scarring, you've lost some weight, you have difficulty walking long distances, but you're able to dress and wash yourself, and you can see it goes on. And there's a little decrement that happens as a result of this. And if everybody had to choose, my guess would be the rational person, and we always talk about that when we're doing this type of work, is the typical average person who is in a rational state of mind would most likely choose being in health state 1. So then you present another scenario, and this is for then a separate exercise, but this shows you where somebody may be indifferent. So for this health state above, the biggest difference, so the biggest difference in health state 2 and health state 3 is you have a lot of difficulty walking long distances, and in health state 3, you have little difficulty in running long distances. But in health state 3, you some of the time feel worried about dying and how your loved ones will manage without you, and you experience some anxiety. Where up at the top, you experience some anxiety and you some of the time feel worried. So both of those have the same in terms of anxiety and depression, but the functional health state's a little bit different. And it's pretty subtle, but you will see that people will read that and gamble between which of these health states better. And we all will have different values for where we choose this. So this is some preliminary work. I've actually done this now in 65 surgeons that are sarcoma surgeons from both surgical oncology and orthopedic oncology. But you can see for this that in general, these are actually, except for health state 3, an inadequate margin and acceptable function, where we see a 0.832. So again, that people are willing to gamble 20% death to be in perfect health in that state. Everything hovers around 0.5. So these are pretty low values for health states in soft tissue sarcoma. And again, all of these health states are following treatment, and they get worse as time goes on, as you move down the clinical pathway. So at 0.36, you see this is an inadequate margin with adverse function. You've now had a local recurrence and no re-excision of that local recurrence. And the VAS held close. Again, these aren't converted VAS, so we can't compare them directly. But here's where kind of the table or the results are moving. So you can see where the surgeon weights these health states compared to the general public, compared to the patient. So you can imagine then, as we were, depending on which of these values we put in a cost effectiveness model, this is going to change the effectiveness of what a certain treatment might look like depending on the perspective we use. So also keep in mind a minimally clinically important difference in this area is 0.1. So we have a MCID between what society prefers for health state 1 versus what surgeons prefer. So in AIM 2 then, I want to take these utility values that you saw in that previous table and put them into a cost effectiveness model. And the idea here is I'm trying to model this, if anybody remembers their microeconomics class, we're looking at the dead weight loss that can happen when there's inefficiency between people's priorities not matching. So in order to do this, I constructed a Markov health state transition model, identify and determine the transition probabilities which you move through the pathway, identify the costs and outcomes, and perform a cohort analysis and evaluation of the Markov model. And then you conduct a sensitivity analysis around those values. Oh, can't believe it. That's supposed to be a Markov model. I'm really disappointed that did not show up, but what we had here is a tree, just like you saw Dr. Davidson perform, and it was an adequate margin versus an inadequate margin. Both of those margins then went into a local recurrence versus no local recurrence. And then it went into a Markov model. So there's a bubble for a disease-free state that then goes into a local recurrence state that can then go into an advanced local recurrence or unresectable local recurrence or metastatic disease state, and then ultimately death. And from any of those states, you can always transition to death. So the idea that you die from something other than your disease. So the significance of this type of work, I think, is to understand this information asymmetry that happens in surgical decision-making. You, the surgeon, possess certain knowledge and experience that then has to somehow be transferred to the patient to make a decision that then incorporates the patient's preference in this setting. And I think tumor surgery is an interesting way to study this too, because if you think about it, I mean, we have great imaging now, but there's always that possibility, and this can happen in any type of surgery. The patient's under, and you now open up the patient, and there's something that wasn't seen before, or there's some decision making that has to happen, and you, the surgeon, are making that decision at that point, understanding and knowing what hopefully the patient's preference is in that moment. And so I think understanding where do surgeons value certain health states, and how you take that knowledge and do you transfer it? Do you have the patient transfer their preferences? I think understanding quantitatively and modeling that interaction is important as we move forward and understand that some of this decision making is going to happen, and we need the people who do this to have a perspective in that. And again, I mean, this isn't just something we will do in soft tissue sarcoma. I think this has applications in all sorts of surgical fields. So that's all I have. Thank you.
I'd like to ask a question. That was nice review, and a broad topic from patient-reported outcomes to medical surgical decision-making. Darin, I'd like to ask you an honest question. We've been looking at physical activity reportings with simple monitors, which have been less expensive over the years and more effective. And there's a high correlation between activity monitors and patient-reported outcomes. My simple formula for patient outcomes is their emotional health plus their physical health over cost. Their physical health is very well reflected and correlated to some of the patient outcomes with just a Fitbit or a handheld phone device. Can't we just replace some of this burden for patient-reported outcomes with a simple monitor of physical activity, since that is the essential sort of sign of success for a surgeon with a patient? Can you use a microphone, please? What's the role of Fitbit versus patient-reported outcomes?
And I think it's a really important topic. And when we look at those studies, if I'm not mistaken, I think the Fitbit and the patient-reported outcome measures of physical function or physical disability correlated very, very highly. And that, I think, though we need to do more studies on it, would suggest we could probably replace the patient-reported outcomes of physical function with a Fitbit or equivalent device. I have no disclosures about Fitbit. They don't pay me, but some other device similar to that. But the quality of life measures are going to encompass a lot more than just the physical function part. So though we may replace, for example, in the tumor world, the test, which is a measure of physical function, with a device like a Fitbit, I don't think that that's necessarily going to replace a comprehensive measure of overall quality of life that's also going to look at things like anxiety, depression, ability to perform functions of daily living. And so maybe we look at a more hybrid model in which we use a Fitbit for physical function to get rid of one questionnaire, and use a questionnaire that's going to look at the comprehensive quality of life that those physical function measures don't address. Is that
Yeah, it would be
Kinda get
interesting to
into
see
the
the
topic.
emotional effect of increased activity in patients with a tumor or a major reconstruction in the extremity or whatever, because there's an interesting relationship.
There is, and having that information specifically is important because there are some studies that show that on those health state utility scores, the domain that's the most variable over time is emotional type stuff, anxiety, depression, and I think we need more information about that specific domain than what we currently obtain.
That was great. Amy, towards the end of your talk, you had a slide that looked at the surgeon reported, the societal reported outcome, and the patient. And I thought that was very interesting. If you could go back to that slide, it was like the
That one?
yes. So
Yeah.
the society thinks that the patient that the problem's not that bad. It's like
Right.
tough it out, suck it up, right?
Right.
Yeah. And the surgeon's like, I can help you, and the patient is somewhere in between. huh?
Right, exactly. And that's been shown in other, not just in sarcoma. So this is actually consistent finding that even patients or society actually rate these health states higher, value these health states higher than do the people taking care of these health states, right? And I think it does get at that idea of, you see the bad actors, you see the word, right? That there is this other group that does well, that doesn't come back. And so the perspective is very singular in that. And I guess, again, it goes back to the idea, probably the societal perspective for all of this is the gold standard. But I think in doing this, especially as you as surgeons will bundle payments and there will be decision making around that, then this myopic perspective of, everybody, society thinks they do well, but then we get into payment issues, and who you're seeing are the people not doing well. And how are we going to account for that? And how are we going to value that? And so I think it is important that all parties are being represented in these.
Thank you, guys. That was really wonderful. I have a question specifically, and Antoinette, you might have thought about this more being in pediatrics. So when we talk about these outcomes related to quality of life over years, and we start to factor in pediatric care versus adult care, can you guys tell us a little bit about how either a positive or negative outcome in a child really affects? Is this much more profound in the age of the individual when the procedure's done?
So I think I'll probably drag Amy and Darin into this a little bit, but one of the biggest problems with doing these types of measures in kids is that when they're really young, the question is, who are you giving, like who's reporting the outcome? Is it the patient themselves or their parents? And then how does their perspective on it change as they get older? And I think that part of why there's a big scarcity of measures and studies about this is that nobody really knows how to measure it appropriately, and then more importantly, not just how to measure it, but how to apply it appropriately. So I think that that's kind of like a big, wide open space for research once somebody figures out how to do it. Anything you guys want to add?
I think the paper on the AYA, the adults surviving sarcoma, the adults that Darin presented, I think show that a little bit, right? That it'd be interesting, probably a better question would have been to pull them when they were earlier on these health states. So when they were experiencing the tumors, and my guess is you would maybe kids are different, right? They actually tend to value their health states higher than anybody else would. But it would have been interesting to pull them as they were going through treatment and then look at them as survivors and see that difference, right? And then I think we would better be able to answer that question.
Just to follow up with that theme, I was involved in the SRS 22 review of scoliosis. Now, scoliosis is no pain. The child doesn't see the problem, and it's only seen by the mother. So how do you develop a program that will go to the insurance companies and say, I'd like to operate on this problem that doesn't bother the patient, only bothers the mother, and it's not life-threatening? And so I think it's the same question you have to ask.
Well, don't sit down yet, Ted. I have a question to come back at you with. How do we know it doesn't bother the patient? Because I would kind of say, if you're talking idiopathic scoliosis, how do we know that it doesn't bother a teenager to have a obvious physical deformity?
Well, the obvious is the question you asked. And the obvious is usually picked up by their general practitioner. Now told the mother becomes keenly aware of the problem, which isn't like that. So I only bring it up as an example of where we've had a lot of trouble developing real services.
Right.
Work with the health industry.
Well, that's why I asked the question, because there's unpublished data that I'm aware of. I won't tell you how, that shows that with mental health screening questionnaires, kids with idiopathic scoliosis screen off the charts compared to age-matched normals on anxiety and depression issues. So I wonder if the reason that it didn't show that has more to do with the measures that were being used than the actual patient experience. And that's where I think all of this patient-reported outcomes, not just focusing on physical function, but comprehensive quality of life, becomes so important. Because I think if we use the right measures, as Antoinette was talking about, if the wrong measure is used in the wrong population, it's like trying to put in a screw with, like, I don't know, the back of a shoe. You know, like, it's just not going to work. And, you know, I'm not, like, the question that comes up, like, they're asymptomatic. Well, are they? Because some studies would suggest that there are serious symptoms that those patients have that aren't physical symptoms, but are symptoms nonetheless, that if we're looking at it from a comprehensive quality of life perspective, we then have really strong data to say, hey, there is a problem here. It's different to what we thought the problem may have been before from the patient perspective, and it may be different from the perspective that we as healthcare providers take to the patient, or at least traditionally have taken to the patient, but nonetheless is an important aspect to their overall health that needs to be looked into and is worthy of being treated.
So I can just follow up about children's instruments. The best studied one is the Pediatric Outcomes Data Collection Instrument, which was developed in the early 90s. And it is, points out what you're saying, that because there's a patient-reported form that the adolescents use from 11 to 17, and a parent-reported form that's used at the same time from 11 to 17 in the same disease state, comparisons can be made between the parental perception and the patient perception, and for the same health state. The health state is there. And as you suggested, it shows that the kids always rate their performance higher, and the parents rate their potential, and therefore their performance lower. But the question I have is relates to these measures and attribution. That this measure truly measures the intervention. So I had a SF36. I had it before my total hip and after my total hip. And my SF36 was much better afterwards. But while I was in the hospital, I won Powerball. and I would like you to tell me, how do you attribute my general health state to my hip replacement or my newfound wealth?
I'm wondering why you've been keeping your Powerball winnings away from the rest of the department. But I think that that's our problem with everything we use to measure outcomes for every intervention, for every study. We just have to look at broader study populations, and that's what we're doing for all these things. We're inferring that it's more likely because of the intervention we did, but you're right, we can't 100% attribute everything to what we do, but again, that's why we have to take everything in context, and everything comes with a caveat. Not one causes the other, and we just have to correlate our findings appropriately.
So one other thought about this, and this is one of the things that drives me nuts with HCAHPS and patient satisfaction of providers, is it all comes down to the numbers, right? So your example is great. Yes, absolutely. There are other factors that happen in life at the same time as an intervention that might have more to do with the change than the intervention itself. the flip side would be, I have my total hip done. Hey, that's gone great. But while I was in hospital, a loved one died. My quality of life now just plummets, right? But on a societal level, if we have hundreds and hundreds and hundreds of these data points, those few outliers are going to fall away, and we're going to get a better sense of the overall mean. So when we get this is your patient-reported provider satisfaction, N equals 8. Go, wonderful. That's great. That means a lot, because that's what, less than 5% of the total number of patients that we see. So it's very susceptible to that phenomenon. But if your N is like 500, now it's a lot less susceptible. And that's where our voice coming back to the decision makers becomes so important, because I'm not sure is there anybody from the hospital here? I don't think so. Listening at home? But the hospital is going to listen to these patient satisfaction scores. Well, if the N is 8, I would argue you should throw that out. What does it mean? It's such a small number compared to if it was more representative of what we see. So that's a great scenario. I think it speaks to the point, and our way to combat that is numbers.
My question is somewhat related to Michael's and the difficulty of defining standards. And so I was interested in how they come up with effectively minimally clinically significant difference for the cost, acceptable societal cost of one increased quality adjusted life year. I would imagine that varies from culture to culture, from region to region, from country to country. Whether you're a Microsoft employee with commercial insurance versus maybe the typical patients that most of us see on a daily basis. And so I'm just curious, how is that supposed to work at the end of all this? And could it have possibly even have the effect of partitioning, discriminating, against certain patient populations, even perhaps more than we do now?
Let's see, I was going to go back to, so very, very good point. This idea of 50,000, what does that mean? And it's been thrown around as a number, but typically when these cost effectiveness curves are done, if they're done well, and I'm trying to get back to one, the idea is that you show it at various thresholds. But the way to test these is doing willingness to pay studies. And so in healthcare, that's a lot harder, because in cost effectiveness, we don't monetize that denominator, that QALY, which we've avoided doing. And so the only way to truly understand the benefit is to then put a money value on that QALY. And so it's not 50,000 per QALY gained. We know you then, for every disease state or whatever, you have to know what that QALY is. And then you lump that into a cost benefit. And so it would change for every disease, for every intervention. And so I can't find the slide right now, but what you see is a good a well-done cost effectiveness study will have that threshold at various levels. And then the idea is you look at the whole picture and take that into account. And that's what's happened at NICE. They do tiering, right? So 50,000 or 100,000 might be their average. And then, if something's 200,000, it's not that they won't approve it. It's in this population with this criteria, we then will approve